Well, again, welcome everybody to the Research in Progress webinar in Public Health Systems and Services Research. I'm your host for today, Glenn Mays. Pleasure to be with you, and thanks to everybody who are joining us in this session today. We have I think, a very interesting research project to step into today and to hear about interesting work happening from another one of our emerging national leaders in the field, and another grantee of our Mentored Research Scientist Award in Public Health Services and Systems Research. As just by way of background for those of you who perhaps have not attended one of the earlier Research in Progress webinars, this is a regularly occurring now webinar series that we're launching designed to feature, again, emerging research findings and insights derived from the implementation of research projects that are focusing on public health services and public health delivery systems, and supported through our National Coordinating Center in Public Health Services and Systems Research, with funding from the Robert Johnson Foundation. We have started this series with current grantees of the Mentored Research Scientist program, in part because they have particularly innovative research projects that are happening in these projects. All of these projects are about a year into their implementation now, and so we're beginning to see early findings, and certainly investigators are beginning to glean insights from their experiences around research design and implementation. So that's part of the rationale. We hope to continue this series after we have exhausted our initial cohort of mentored research scientists awardees, and also begin to open up this seminar to other grantees and other investigators who are proceeding through research projects in this space. So for today, we are very pleased to have some colleagues from the University of Minnesota School. University of Michigan School of Public Health. I know that is a major faux pas. Colleagues from Michigan to talk with us about ongoing research today. Dr. Holly Jarman, who is a research assistant professor in the Department of Health Management and Policy there at University of Michigan. She is, as I mentioned earlier, one of the scholar awardees in the Mentored Research Scientist program in PHSSR. And as all of the funded scholars in this program do, she also has a senior research mentor to help guide her along the way, and he's coming into view now in the webcam, Dr. Peter Jacobson as well. So we're very fortunate to be joined by both Holly and Peter today. Let me just give you a brief bit of background on these two esteemed colleagues, for those of you who may not already know about the great work that they have done and are doing. Dr. Jarman, as I mentioned, is a research assistant professor in the Department of Health Management and Policy at Michigan. Prior to that, she spent some time on the faculty in political science and public policy at the University of Albany State University of New York. She's done work broadly in the areas of international public health, as well as in health law and health policy. Work looking at the organization of health departments in public health agencies, and work looking at information sharing and governance among public organizations. She's got a Ph.D. in government from London School of Economics and Political Science, as well as a master's degree from political science from that institution as well. So brings a very interesting, very important perspective to the work of public health services and delivery systems, especially from political science and public policy. Again, her senior mentor, Dr. Peter Jacobson, is also well known to our PHSSR family and field. He's a professor of health law and policy in the same department there at University of Michigan School of Public Health. Also serves as director of the Center for Law, Ethics, and Health at the University of Michigan. And he has has accomplished a broad and extensive array of scholarship and research spanning public health, health policy, health law in many different substantive areas. And so he's a resource and a mentor to many of us who work in this field, and I include myself in that category as well. So without further ado, I think we would like to turn it over to Dr. Jarman and to her colleague, Dr. Jacobson. Thank you so much for being with us today.
Thanks very much for having us. So I'm very happy to be doing this. I'm going to try my best to look at the camera and deliver my talk at the same time. Please feel free to write your questions in the chat window anytime. We will try to pay attention to your questions, particularly at the end. I realize that most of you don't have audio, but it would be helpful if at least try to use this nice technique to have a bit of a discussion. And so I'm going to be talking to you today about collaborative governance in the context of health information exchange, which is an activity that we've been seeing quite a lot of talk about in the last couple of years and some degree of action on. And I'm very interested in the governance side because I'm looking at how federal policies essentially have been implemented on the ground and how they're really affecting public health outcomes in reality. And we're still at the fairly early stage of implementation of some of these measures, but I'm that I can show you some of my work today and show you how that implementation process is progressing and how it isn't. And so a brief definition, I suppose, for people who don't really know what health information exchange is. It's not just for electronic health records, I think, my first major point. The HIE in general, we would define as the movement of health-related data in electronic format from one organization to another, usually by automated means. So we're collecting information and ideally, in an ideal world, pushing it and pulling it back between organizations. And also in an ideal world, anybody should be, who has a relevant interest, should be able to query that information. As I think you'll see in a moment, we're quite a long way from this ideal at the moment, but some of the groundwork to achieve it is laid currently. And so the history of this as a policy issue at the federal level goes back to the High-Tech Act, 2009, part of the big stimulus package that the government passed. And so this is obviously not a new talking for a number of years, how to take advantage of technology and improve both healthcare and public health. And this High-Tech Act, though, was a catalyst in that regard because it contained funding streams and emphasized funding streams for implementing both electronic health records and other automated systems. But then also focused on this issue of health information exchange. The main idea behind this was to avoid having health silos, if you like, of information and think about better ways to connect those silos together to benefit. And I think this debate was largely framed in the sense of healthcare. Public health was really, to some extent, out in the cold for a while, but at the moment the debate is turning much more towards how some of these systems purposes. So I'm very interested in that question. And there are some very big claims made about health information exchange basis. But I would like to really focus on the potential benefits for population health. And I think by studying the governance process, I can some of the roadblocks to achieving those benefits, judgment about how to And this is a very appropriate topic for a PHSSR grant because I'm really talking about the integration of services and how technology can or can create those. So a brief overview of the kind of research. And essentially I'm asking how health information is leveraged to support public. But I've been doing this in a very ground-up way. So I've been working quite extensively now over the last year and talking to them and then interviewing both people at the state level, officers in local health departments, and a number of people, a statewide health information, Michigan Health Information Network is a body that was set up specifically to promote health information exchange of federal grant money. And so that organization contains both clinical people, contains people on the technical side, one or two of whom are from actually other industries. So we're used to working in IT and had to come to health and deal with a much more complex set of questions. And also talking to providers who have been at state level. And so these interviews were semi-structured, meaning that I outline an interview protocol, but the person that I'm in, their expertise. And the point of these interviews and really with working with the Department for Community Health is to try to identify what facilitate public health. And to that end, I also conducted a review of a lot of primary policy documents. So this is largely a synthesis of a lot of internal laws and regulations, looking at policy documents, plans. And so that textual review helps support the governance story. One of the things I also wanted to do was place Michigan in the context of health information whole, and to do that I've been looking at survey data. There are a number of sources of survey data which are nationwide, and largely that data has been looking at counting health information exchanges. How many of these organizations exist? How many are functional? How many are actually sending live data? And within that, how many hospitals and how many doctors are actually? It's a huge problem for health information exchange and, in fact, EHR adoption. And from that, I can say that Michigan is actually a nice case and a very generalizable case in that sense, because we are about average across those surveys in terms of our HIE implementation and in terms of our EHR adoption. But what we really are doing for public health is facilitating a lot more exchange of public health information than the average HIE that we find across the so to talk about the potential benefits that are posited. Now, we have to be incredibly careful because the literature that does exist does not focus on public health. There are still very few studies in the literature in general, particularly about on-the-ground decision-making concerning HIE and public health. So the exchange of public health data such as stations, records, lab results, to some extent syndromic surveillance, which states are experimenting with pushing through. And so the literature is very expansive in HIE in general about the benefits. It is essentially, I would say, a magic bullet in some respects, considered able to save money at the same time as raising quality of care, at the same time as doing other desirable things, facilitating public health. And so when I compare what's written in the literature about these studies to what my interviewees discuss, my interviewees really hope for more modest benefits. They want to see their job done better. They want what they do facilitated by HIE. So to the extent that HIE can give them the data that they need, or more detailed data, or even more accurate data, and do it faster and facilitate faster investigation, for example, that's what they want to see. They want to see that they talk happily about the possibility for real-time reporting. They talk about wanting to see more accurate graphics, and they talk about better identification strategies. Some of, and I would say that a number of the benefits are delivered, and we are coming to a crucial point in funding for aid where the federal government is discussing, has delayed, in fact, the next round of requirements which could support HIE. That's very important. Public health community is very late to this. Nevertheless, I hear a lot of positive support. What they don't want to see is a wary of added bureaucracy, particularly in local health different systems, and as we surveys the systems that they use, multiple systems, makes their job more complicated. Nothing that adds to that. And so, where does Michigan stand in of where we see health information exchange and public health in particular across the country? And this is taken from, and actually an RWJ-sponsored survey, which I believe out of the current national surveys, one problem is that they are all funded in some way or another by either grant funding or through the fees. So the eHealth Initiative surveys, which are funded by, and so I think this is the best, most current data that we have, and I think clear. But in terms of public health department participation, what we see is health departments do participate. So 58% of all HIE efforts across the country involve a public health department receiving some information. But of course, receiving is much easier than actually being able to push that information out to organizations. And so that number drops to 37% about public health departments sending information. And of course, that doesn't tell us very much about the granularity of that information, the quality of that. And in regards to these surveys, we really are talking about meaningful use criteria, which I think are a fairly low standard for the exchange. If we look at the meaningful use criteria which pertain particularly to public health, as you can see, they're again rather simple or relatively simple categories, but have been, I think, practice difficult. But public health departments are participating, but at a much lower rate than you see. We're talking about the more healthcare oriented. So in terms of submitting immunization data to statewide registries, that accounts for 39% only HIE efforts. That HIE efforts, organizations across 39% of the time doing that. Syndromic surveillance is really one of the more complex activities, but nevertheless it is still being pursued in efforts. And here is an example that shows you how public health is behind. 60% of efforts incorporate some kind of lab test results into EHRs as structured data, which is one of the significant meaningful reporting criteria. And yet, with reportable lab results and sending those required lab results to a public health agency, that's not happening nearly as much. That's in fact, out of all the meaningful categories, both healthcare and public health, that's the category that's receiving the least attention. And so my point here is to say Michigan, it could potentially be a model in this regard. It is doing more than the national average regarding the public health criteria. And in part, I think, because of the strength of a couple of initiatives at the state level. Nevertheless, we're clearly, everybody is, needs attention to these public aspects of missing a significant opportunity and to get some better data health work. Now, here I'm going to show you, I'm going to move on to talking specifically about Michigan. And this is the simplest diagram I could come up with for a PowerPoint slide. I have some much more complicated sort of network diagrams. And in the end, I would say that we can characterize HIE in Michigan as incredibly fragmented, to the extent that sometimes we show up in surveys as being one of the best states for HIE because we have so many organizations that are health information exchanges. And I think that's a significant problem. It's really, with any kind of IT, looking for is a degree of consensus. You're looking for the opposite of fragmentation. You're looking for and so on the left side here, I have in the yellow box, or I want to say maize and blue because I was going for Michigan, University of Michigan colors. In the maize box, we've got the Michigan Health Information Network Shared Services Hub. Now, this is a statewide network that not specific to public health whatsoever. It is concerned with exchanging, pushing and pulling data back and forth from providers, hospitals, labs. And the problem here with fragmentation is underneath my list of sub-state HIEs is rather long. And one of the things I did for this project was to construct a timeline which looks at each of these in practice, what their origins were, how they came to be included in the first place as a sub-state HIE, how they became what's known as a qualifying organization under MyHIN, the Michigan Health. And so some of these bodies have been very ephemeral. They have lasted for a short time. And some of these bodies have received state incentive funding, which was appropriated by the state legislature back in. And they received that funding as pilot funding to basically try to establish at least the key concepts and standards that were required for functional aid. And then really the federal funding has been used more, less in a pilot stage and more try and put some of the practice. Again, we're talking about a very low level of live exchange. I would say MyHIN has not been functional for a very long time. It's been live on foundation data and lab 12, but there's been years of planning before that, going back to way before the High Tech Act, going back to 2000. In the blue box, on the right-hand side, we've got what the state of Michigan Health Information Exchange, which is more of a virtual idea than an independent organization, housed within the Department of Community state level. And so underneath, I've listed the major things which they are targeting as public health applications for. And so really this side of the infrastructure is built on existing infrastructure that exists within the Michigan Department of Community. Particularly, for example, what's always highlighted as something that we are doing fairly well in Michigan, organizations register. And so to some extent, the department were able to build on some of the things they had already, where investments had already been made. And so one point I would make about this slide is to say that where this works well, where HIE works well for public health, it is because the relationship between the state of Michigan in the blue and Michigan Health Information Network in maize is good. It's because that relationship is good. It's because governance works, and it's because Michigan had an existing property and was functioning. Where it doesn't work so well, it's because that relationship breaks down, as I think I'll explain when I talk. And so this was an initial legal framework. It was a political requirement to have many different sub-state HIEs, and that was driven by a genuine desire, I think, to make sure that provision was spread throughout the state, and to try look at the early policy documents. They were at least trying to push this, talk about patients and talk about public health applications around. I think in reality, what is missing, as I'll show you in a moment, is public and community benefits to this infrastructure. So when I take a look at governance structures behind, so again, we've got on the left, MyHIN, the statewide exchange, the state of Michigan HIE on the right. The HIE efforts within the state department are coordinated by the Michigan Health IT Commission, which is a body established by state law in very early 2006. And so that body consists of a wide range of stakeholders, and these stakeholders are represented as defined within that law. So this is a legal framework which, if we wanted to add representation to that framework, we would have to change the law, which is difficult. And this creates a rather fragmented body on the Michigan Department of Community Health side, because we do have government representatives, so the Chief Information Officer for the state, and one representative for the Department of Community Health. But then again, the other stakeholders which are sitting on this body and making the policy decisions which are supposed to steer the HIE efforts in the state as a whole. We have providers, we have a number of business interests and vendors, 4 different representatives of professional communities, and 1 representative which represents consumers, and that's the word that's used, and not patients, not community focused person. And so in practice, what happens is this body tends to become a monitoring body. They monitor progress within the, I would say they don't do a lot of high-level policy steering, and that in part is governance. The board of directors for the Michigan, move over to the maize side. The board of directors for MyHIN is equally fragmented in terms of its representation, but this is what we would expect here. So this is a public-private collaboration. It's a 501c3 corporation. So this is then established as the state-designated agency that's accountable for the operation of health information. And one of the reasons that public health is in that debate at all is that we have a public health representative on that board of directors, along with the providers, the insurers, the professionals, and 1 consulting firm. And so this side of the slide is, this body is supposed to be responsible for operational activities day to day. In practice, I feel that they are much more directive on the policy side than was originally envisioned in the governance structure. I think the extensive input of stakeholders in both structures. Now, normally I would be talking to you and saying that transparency and inclusion are incredibly important. I think the difficulty here is that when we are trying to see clear direction from those who are accountable for policy and political direction in the state, this amount of fragmentation makes it hard, makes that job hard. And I think in health information and health IT applications, what we want to see is not necessarily fragmentation. And so I might raise questions that we can maybe talk about in the about the extent of to which this was established as an incredibly open stakeholder participatory mechanism on both the policy side and the operational side. And that has practical consequences for public health because we're not seeing so much as of a policy push from the department and from the state as a whole to make sure that what's done serves communities with the state. So what are they actually doing? And this is a huge question for health information exchange as a whole across the country. The extent to which live health information exchange increasing is very rapid, but from an incredibly low base, particularly in a very low base which is affected by electronic health record adoption among physician offices. So hospitals and labs participate a large amount of the time. But what we're seeing really here is not so much of participation by doctors' offices. That is driving a large number of these use cases on the public health side. And when I speak to people in the department, one of the things that they are trying to do with the use development list, they want to see things that they can offer those physician offices, have real value for them. And when they're constructing the public health use cases, they want to see real things of value to public health officers, want to see benefits from, as I said earlier, don't increase bureaucracy, bureaucratic burden on them, do help them talk about community slightly more efficient way, perhaps. So in production, which means functional, immunization submission, reportable lab submission are working 12, and Michigan in being among the smaller number of states where this kind of public health use cases in pilots. Syndromic surveillance is being piloted currently, and positive things developing. I think in here it's make it absolutely clear. The case title doesn't really state it. It's Michigan Department of Community Health, which is receiving the syndromics, and then there are more complicated. I haven't put them here because there are a list of 24 use cases working on. So the more complicated versions of not just immunization submission, but the ability of organizations to pull immunization data or pull syndromic data from the central hub is still a use case that's being worked out. And so then rather quickly, actually, the cases in development, the department's trying to do what I think are some interesting things. The cancer registry is something which Michigan is a bit of a laggard. This is going on in states across the country. The officers in the department found it very easy to set this one up, and they're hoping to put it into pilot stage very soon, mostly because there were central resources that they could use to attempt to, there were models that they can use. There were examples of other states they could rely on that information. Birth defects registry is something which is much newer for Michigan. And really the officers talked about having to construct a number of having to construct the framework for this registry fairly from scratch, essentially. And in that, they have had to go and partner outside vendors and consultants, in part because there's not a central resource for them, not a clear model, and that plays an enormous role of this kind of. And so one of the most controversial things, which I'll talk about more in, is the state is trying to develop a master person index. Now, nationwide, in terms of exchanging health data, we've gagged the federal government essentially from talking about individual identifiers, unique identifiers, part because of questions that it raises about privacy. And the state is going ahead and trying to, essentially for demographic purposes as well as purposes. Very interesting to me. I'm going to be following. The reason for pushing that is that they need better ways of identifying duplicate records, making sure that the person that is identified by the record is actually genuine in terms of they have the right patient, for example. Big patient safety. So just going from that pipeline, you can see what a low level really we're aiming for with public health. And you can also see how the state efforts, essentially, I think are more robust, and the existing state efforts are more robust than what has emerged from separately funded activity. What I don't see, and I do see to a greater extent in Michigan, but in other states, is an extensive connection between the EHR side and the public health. So this raises some governance questions that I'm particularly interested in, because the governance of this eats up money. It basically directs the form and structure in which the exchange will take, and what's recommended from a governance side, from a policy perspective, is not always what is needed from, if you asked somebody in the, probably say, don't be fragmented, don't have a network of networks. Because fragmentation creates more complexity, and that complexity is difficult to overcome, and you need more innovative technological. And everybody I talk to in the health IT field is worried in general about HIE interoperability as it. Secondly, the problem with the Michigan case, I think, is the incredibly large range of stakeholders, and a number of these sub-state HIE disappeared, and they failed financially, failed organizationally. There were really no failure criteria, I think, established at the state level. And what we saw in the state is an initial wave of applications to become a sub-state HIE. And I think, really, if you look at the policy side, what the policy structure was set up to do was ensure that there were a wide range of actors there, because those sub-state HIEs today were supposed to become tomorrow's fee-paying participants that would fund statewide HIE and keep it sustainable. So the criteria for including sub-state HIEs, for including organizations within the statewide HIE structure, were incredibly broad. And in the converse of that is there were not very effective criteria designed to establish when has a sub-state HIE failed. And particularly on the public health side, we will want to see, is the information that's being collected actually accessible? And people in the State Department talked a lot about trying to make that data accessible, because initially they were seeing data being submitted to statewide hub, which was not going to be accessible for public health people in the state, and they correct that. Secondly, one of the concerns is the representation with HIE governance. there's a lot of talk in the primary documents that are made about including patients and community. And I think, and also the inclusion of public health actors. Over time, what we've seen is more inclusion of public health actors, particularly at the State Department. But we haven't seen a great deal of patient and community representation. And that's a concern to me because that the stage 3 criteria at the federal level, the federal debates are in part about delivering more for patients, delivering more for communities. And we'll find that it becomes. And so ultimately, though, I think there's a conflict of interest here. On the one hand, the state really wanted to create a broad structure which brought in all of the stakeholders, with an eye to those stakeholders becoming future fee payers that could sustain the HIE income. And that conflicts a bit with the idea that the state should be there as a strong presence supporting the public interest and supporting, from our perspective, supporting public health applications for this activity. And secondly, the other area of concern is really the ethical questions. Now, I mentioned that the state is constructing a master person index. And there are two ways to try to make sure that the person, the record that you're seeing, matches to a real person and it matches the right person. One is simply give people an identifier. And in general, we find that this works perfectly well in systems with health systems with single payer. If you look at the states in the US where they have extensive healthcare coverage with it, they do better at identifying patients. That's not feasible for most of the rest of us. The second best solution is to come up with an algorithm that effectively matches patients to the correct records. And so for a long time at the national level, that's become. Now, this whole question of patient mapping and government record collection has been a debate for a long time. But in Michigan, it's also been a debate. Michigan has a very successful program for collecting blood spots from newborns. Praised, but it's also been critiqued, and it's been critiqued by communities, by parents who feel like that data was collected without them really understanding how it was going to be. So there have been questions about, and at the moment when I look at examine all the state documents, all the meetings, all into and talk to the people who are working on this, they are still working out structures of consent. This potentially, that's an issue that really. So where I'm going, I'll talk about where I'm going with this project. But at the moment, one of the biggest problems for public health and HIE in general is that it needs to be more ambitious, a more ambitious directive, I believe, from the federal level. We've had meaningful use stages 1 and 2 for electronic health records, where the stage 3 criteria are currently heavily delayed. The feds are still thinking. There has been a number of calls from statewide HIEs, health departments, public health criteria included, that justifies some of the activity that I've been talking about, would like to see happen on the ground. Secondly, in some states, there's just clearly a lack of awareness that this could be public health agency in general. And it's not, what I've been doing on that point is really working with the Michigan Department of Community Health. And essentially, we're trying to think of ways to recreate the fact that in the Department of Community Health, we have offices containing public health actors and health services people in close proximity to one another. The story of Michigan, the funding that they received and the things that they have managed to achieve so far on public have only happened because of that proximity, that working relationship, and awareness that they could leverage what was going on EHRs to support HI. And so we've been second year developing some public health people around the state, but hopefully they will be generalizable. Thirdly, the extent to which this implementation process is very clear. This is an incredibly low level PHI adoption. And from that low level, I think there's been rapid progress, but we're reaching the stage where sustainability is going to be a huge. Finally, I would say not all governance structures are equal. What do I mean by that? Really, the fragmentation was a deliberate political decision in Michigan, and it has been detrimental to the actual functioning and the interoperability of data. So I would posit that there needs to be a clear public health interest incorporated into the stakeholder structure. And I think that consulting stakeholders is something to do, but not necessarily at the expense of clear policy direction. Public health. Okay, I'm running it. I'm happy to talk about where I'm going next with this states, but I want to hand things over to
Actually, why don't you do that first?
Okay.
I think that's more important.
All right. So I'm halfway through this project. I'm moving to year 2. And essentially what I want to try to do is, Michigan has a range of agreements which govern interstate exchange of data, not just in geographic proximity, but also in other states around the world. And I would really like to try to understand the extent to which that can be used for public health, particularly as this exchange is done through direct. It's done through direct, secure messaging. Not always, it's probably the least amenable form of data, which is actually helpful in an aggregate sense and helpful for public health practitioners. There are some concerns about accessibility to the data. And so I would like to think about the state connection. And I'm going to starting our bio, where there is very well developed interstate exchange. Okay.
Great.
I'm going to angle the camera a bit so you
Thank
get
you.
some Peter.
Hello, everyone. I haven't seen any questions yet in the chat room, so I want to make a couple of comments and hope we'll get some other questions in the interim. I'm really pleased with how your work is coming along. I think you raised some really very interesting and important questions for us. A couple of things occur to me out of this work so far. Some negative and some positive, or if not negative, not about your work, but about sort of the starting position. And it looks like here again, public health is subordinate to other interests.
Yes.
So how do we move? How can we start to incorporate public health at this point? Is it too late for that to happen? Or your interview suggesting that there's a willingness to incorporate public health?
They are willing. They want to see. Sorry, let me move back a bit.
Okay,
then you can get both
there
sides.
we are.
Hi. Yeah, they want to see public health incorporated. I think essentially there's a point of opportunity right now to influence meaningful use
Right.
stage 3.
Right.
The federal government has an opportunity to make public health and population health a priority, and I think that top-down investment in public health has to come.
Okay, but does it have, can it come from the state? In other words, can the state expand public health use, still meet the federal guidelines?
To some extent, yes. So the meaningful use stage 2 criteria, for example,
Right.
have some more complicated
Right.
requirements, which are, but I
Right.
think it's within the states. What a lot of states face, I think, is that the public health interests are hived off politically, they're hived off
Right.
organizationally,
Right.
and so that capacity, the capacity to incorporate public health might not be there on that side, it might not be there financially.
Right. So a more positive way of looking at it, it seems to me, is that there are great opportunities for public health on a number of dimensions. One is becoming more integrated into the health system through and using provisions in the Affordable Care Act become more ingrained and more integrated, I think is still the word I want. Second, it's an opportunity to demonstrate value for public health.
Yes.
And that's the frustration that I'm hearing out of your talk. There's such an enormous opportunity here. How can we take advantage of it? So I guess another way of looking at it is, what do we as public health practitioners need to do to move this? Not just as researchers. I think your research is going to provide some real insight into the difficulties of using this kind of structure for public health purposes. All right, then how do we respond to that? I mean, what would you recommend in terms of the program, the PHSSR program, using this work to work with a network of practitioners?
Well, I think actually one of the nice things about the PHSSR, giving you all a plug here, but I would really like to partner with some people who are doing a lot of public health value. Great presentation. I think the value of public health HIE, you could take like the immunization records.
Right. So the positive case.
Get some data on that. That could be a very powerful policy advocacy, essentially.
Right. So the positive case here is that there are still lots of opportunities.
Yes.
If we can figure out a way to change the governance structure, get more involved with public health, and maybe there's maybe a follow-up kind of policy brief to the Michigan Department of Community Health and other state health departments as you go along and develop these information exchanges. Don't forget about public health. Okay, so
sorry, we've got a great
Julia?
question here from Julia. How does Michigan deal with patient consent to public health use of individually identifiable health information? Opt-in, opt-out? Well, it's opt-in. I'm going to scroll up, sorry. What are implications of optional participation? Yeah, this is incredibly difficult. And one of the reasons why there's such a lag in my timeline in terms of on the governance side, the development of this kind of public structure is just a constant topic, constantly now even, of debate amongst the stakeholder boards, both in the department, the Michigan Health IT Commission, and the MyHIN statewide network. And this has been, for example, the debate on mental health alone. What the people on the ground want to see is a standardized format. They want to see a standardized form that they can use. It's an opt-in system, so they are then struggling with questions of how is that combined with various education to try and make sure that there's the people who are signing the form understand it. And so that's been a huge question, and I don't think it's resolved at all. And that's one of my points of contention, I think.
And an important one to pursue. We also have an interesting comment from a guest who talks about the development of these systems to maximize Medicare reimbursement rather than to build an integrated infrastructure for basic use. So the guest talks about the lack of financial incentives to motivate the state. How have your interviews identified that and talked about that?
Yep, so they talked about this a great deal in the State Department. The way that they spent more time on this in the first place is because, as I said, they have that proximity and that working relationship between the healthcare people and the public health department, and they extensively work together to seek this funding, basically.
Right, but
the healthcare people identified the funding opportunities. They said, hey, they took this to the public health people across the hall, and they worked together to try and build this for the...
Okay, but do they see, I think you've answered this, but they don't see public health as a distraction or a drain on funding that would otherwise go toward a different development. Rather, your respondents are saying that there's value in having public health. Is that
that's
correct? Okay.
And they don't see it on a drain as a drain in funding, in part, I think, because they have a long-term good working relationship.
Have they talked about potential savings through better public health prevention or use of data, surveillance?
They have talked about savings, but they, I think, are very cautious in talking about that because of the low level of implementation. They are cautiously optimistic that there will be more savings, but it's their real focus is on how this can improve population health in the state in terms of cost savings. They're more cautious.
All right, that's fair, but at some point of development over time. So Brian Dixon asks, how can public health expect to benefit from HIE if there's not yet an MPI to allow for robust episode definitions and linking across vital records registries, etc.? Master person index.
No, and I agree with that, and I think that's everybody I talk to at the state level, at least, said this is the thing we have to do, this is the thing we have to accomplish, and we have to get that use case development, but it's been in pilot stages. And I think in part that may solve some of the siloing that is continuing between stuff that is governed, the registries that are governed currently, the stuff that's being governed more by MyHIN. And I think that problem, if it's not solved by sorting out the MPI, is soon going to become a lot worse, because MyHIN is moving from an incredibly low level, but moving towards more live stuff in production.
What about capacity constraints? Your interviews indicated any capacity constraints?
I'm focusing more on the human resources side. A lot of the people in the department are doing this as a labor of love, and they're doing this on the public health side in addition to their current roles and jobs. So there's not so much of an independent set of
I hate to cut off such a great discussion, but we are at our time. And so I just want to come in and again thank you both of you, both Holly and Peter, for sharing with us some very, very interesting and very, very important work that is still underway. I hope that we and others can contact you if there are other more specific questions or ideas that people have, and I'm seeing nods, so that's great. And this is still work underway, so we're eager to continue to see how this project develops as things move forward.
Yep.
So again, thank you both.
Thanks a lot for having us.
All right, thank you.
Absolutely. And as we close out, just a reminder, we do have next week's installment of this Research in Progress webinar will be our fourth and final member of that first cohort of mentored research science scholars, Dr. Janine Harris and her mentor, Dr. Ross Brownson from Washington University. So please tune in for that, and then we will begin to open up this seminar series even more broadly to other investigators in our field. So thanks so much for tuning in today. Contact us at UK if we can be helpful in your own work, and look forward to seeing you next week. Thanks so much.
Bye.
Thank you very much. I've got to figure out how to